Welcome to Washington Hospital Today, dedicated to informing residents about healthcare topics and issues. Through programs featuring community forums and free health and wellness classes, our goal is to empower community members with the information needed to make informed health decisions. Washington Hospital has been providing healthcare to the residents of the Washington Township Healthcare District for the past 60 years. Today's presenter is Dr. Jenny Tran. Dr. Jenny Tran is a gynecologist with the Washington Township Medical Foundation.
Hi everyone, thank you for coming. It's such a nice day outside, but not a great topic to talk about in cancer. But we're here to talk about prevention. So today's topic just includes most basically breast cancer, uterine cancer, which includes endometrial cancer, ovarian cancer screening, cervical cancer, which is all female related, and vulvar cancer, which is not very often talked about. And I add in colon cancer because as female, we tend to forget that part in cancer screening. When you present to an OB/GYN, like myself in the office, I kind of run through these kind of screening with you briefly with your preventive visits. And so I like to bring that topic up today with colon cancer too. First off, talking about breast cancer. So breast symptoms that most patient comes in. A lot of times patient comes in for breast symptoms, lumps, bumps. Really, majority of patient comes in with pain. New changes in pain in certain areas of the breast. Nipple discharges is very common. Not so much skin changes. I think part of that because not a lot of female do a thorough breast exam enough to see the skin changes, but definitely pain is the #1 reason that most patient comes in to see in our office. And then the other things that we follow up is mammogram abnormalities. Sometimes you get a screening mammogram and something pops up. We kind of follow up with that with further studies. And then usually that comes with breast ultrasounds. And then very often we forget the family history part. When a patient shows up in the office, I'm very anal about pretty much going through the family history, and I will sometimes catch like multiple patient with multiple family members with breast, endometrial cancer, even colon cancer they don't really think about. So family history is very important when you come to the office. The other times are sometimes trauma to the breast. You hit wall or walked and exercised, or a dog jumped on your breast or something like that, which is kind of a strange complaint, but I've heard several times my dog jumped on my breast, and sometimes that patient will come and then come with breast pain, and then we worked it up and somehow we find something more than that. Also infection, believe it or not, I see a lot of postpartum moms too, and so they have mastitis infection, but a lot of times they're spontaneous infection. So when you come to see us in the office, the first thing is if you have breast pain, we want to make sure you have a screening mammogram. A screening mammogram, just to let you know the difference between screening and diagnostic. Screening is just a 2-view, generally, one oblique, one on the side, one depending on the. Many of you have had some of you have mammograms, so you would know it's just a 2-view. Diagnostic mammogram is really to look for more. So they do more further imaging, sometimes looking at a different view, focusing on a lesion. So when you come back with a screening mammogram, if a workup is, they found something, the radiologist would actually ask for another mammogram, and that's usually followed up with a diagnostic mammogram. If there's a breast lesion, then we usually do, or breast lumps or cysts that they see, we follow up with a breast ultrasound, or dense breasts that they sometimes can't see anything, can't really differentiate or can't really determine what exactly is on the diagnostic mammogram, but the lesion's there, so they go further with the breast ultrasound to help. It also helps guide biopsy. Radiologists do the biopsy in their department. And also for surgeon, if you were to follow up, let's say you have a cyst that was 3 centimeters, it looked benign, but you want to remove, or we looked suspicious, we want a biopsy, it's a way for the radiologist, whether it's a radiologist or a surgeon, to do the biopsy removal. Thermosynthesis is just another form of the mammogram. It is a little bit more than the screening. It's replacing some of the screening mammogram. It is still a 2 screening view mammogram, but it's still a screening. For thermosynthesis, is actually now recommended more for dense breast tissue, patient with dense breast tissue. The studies have shown that it decreases the false positive from a screening mammogram than traditional mammogram. So if you have dense tissue, it's sometimes we suggest doing the thermosynthesis. Not all places offer that, so sometimes something new. It's now coming up and coming more often. We're seeing more. MRI is more specifically for if you have a family history or very high-risk patient, for instance, a strong family history of breast cancer, or you have the Guild model, if your breast cancer risk is greater than 20% in a lifetime of forming breast cancer, then breast MRI is suggested to see the lesions a little bit better or examine the breast better. But the thing about not offering an MRI, for some patients they ask, why do I not go for MRI straight to MRI if they found something? The problem with MRI is it picks up a lot of things, a lot of false positive as well. So if you're low risk, no lesions, nothing to follow up thoroughly, then MRI is not suggested, and it's pretty expensive too. But high-risk patient, we do suggest, especially like BRCA positive patients who have high risk for breast cancer, should get an MRI almost every 6 months to a year and interchange with mammogram. I throw in thermography because I've had, and it is not well studied, but it is out in the community. I've multiple patient comes in and asks me, is it better than the screening mammogram? I tell them it's not well studied, and I prefer if they do choose it and they're low risk, that it is there, the studies, there are some benefit to it. It is heat sensitive, I don't know if you guys know the difference, but I tell them that if you feel the need to decrease the radiation, and the fear is why people choose the thermal is because of fear of radiation. If you're a low risk patient, you want to do it every other year, it's fine. But add in the screening, the traditional mammogram, so that we have something to follow up if you do have something concerning. So when you do have mammogram, we get a mammogram, a screening mammogram, or diagnostic mammogram. These are the category that comes up. I bring this up because if you're a part of my chart online message, you get now or actually can see your mammogram results. And the results come with BI-RADS, and these are category that the radiologists use. They're just a way of communication, but also to say what are your risks if you do have something finding. 0 usually comes with patients who a lot of times have dense breast tissue, have lesions, or mammogram they have done somewhere else, and they found something on this current mammogram and need a comparison. So usually it's 0 until they get the comparison or further diagnostic mammogram. 1 is the best, obviously, negative mammogram. Benign is just they find something, but likely it's not cancerous or any malignancy risk. 3 is usually probable benign, and then they ask for a mammogram, a diagnostic mammogram, and then a follow-up 6 months generally is a shorter interval follow-up. 4, then the risk increase, and 5 and 6 is no malignancy. But 4 and 5, we call you into our office and discuss what's the next follow-up. Biopsy is really recommended. Usually either the radiologist sees something and they would recommend an ultrasound guided biopsy or a surgeon to have removed. And then I throw in the dense tissue because a lot of everyone's like, oh, why my tissue's always so dense? It is there because it is true, dense tissue does make mammogram reading a little bit more difficult. Again, that's the reason why the other screening options are offered. But it's something just to keep an eye on, know that you have dense tissue, and it's just, if you have any concern, follow up, more imaging is always warranted. But dense tissue doesn't mean that you have increased risk, it just means it's harder to read on a mammogram. So biopsy, radiologist does them or the surgeon does them, we refer you to them. And then for referral, generally it's the breast surgeon or general surgeon here or breast surgeon who will do the consultation, biopsy, and surgery, looking at the results and decide what is the best in terms of diagnosis and treatment if you do have a lump or a cyst or a lesion that needed to be biopsied. So who usually sends the reminder? We do. Sometimes we send you a reminder, but the radiology department usually sends you a yearly reminder when it's time up. They're really good about it. A lot of you seem to probably have a mammogram at least once, and you get a letter and a reminder. Your primary care can also order the mammogram if you don't see any of the OB/GYN. So it's good. There's always someone reminding you the mammogram is important. So in terms of prevention, this is where a lot of patient comes into my office and they're like, oh, I didn't know that, I didn't know this is how it is. I really stress the importance. The ACOG and some of the guideline task force goes away with self-breast exam. They think that too much false positive is from patients over-examining themselves. I think in some way it is, in some ways not. But more importantly is self-breast awareness is really important. I always recommend a patient to do at least once or twice a year. Really know what your breast is like. Your lumps and bumps are not the same. For you or I, for another person, they're all different. But your lumps and bumps are yours, and the changes are what is really important. So self-breast awareness is really important. And to do a breast exam, there's many different ways, the sitting position, the up position, the shower position. I tell a patient to do a breast exam, I'm a lay back person because in order to move your hands up, you can do the breast exam and check the under breast a little bit more carefully. It's usually more miss if you do it on a standing position. So for that reason, you can do many different ways, but as long as you know what your breast tissue is like is very important. If you still have a period, most patients don't know this, but if you have a period, check it the week after you're done with a period. That's when your hormone level is lowest. So that's when you check the breast is not tender, lumps and bumps that generally comes with hormones are not there. So it's very important to check it after. Don't check it before because it's always painful. The other thing about, and I notice a lot of patient comes to the office, is also they get yearly exam, but they always say, I don't know how to do a breast exam. Then ask your doctor how to teach you how to do a breast exam. If you're concerned about a lesion, please ask them, is this normal for me, or is this normal? Do you think this is normal? The screening mammogram, different guidelines have given different age of starts. So for ACOG, which is the American College of OB/GYN, we have set 40, start at 40. Some have said after 45, some says after 50. Earlier, if you have family history of breast cancer in your family, and then ends anytime that you're done. If you have less than 10 years lifespan and you feel like you don't want to do anymore. And really the idea I tell most of my patients is, if you want to stop mammogram, if you know that if you were to be diagnosed with cancer, would you go further? Would you do more aggressive treatment? And that's when you want to stop. I have an 89-year-old who is very active and moves around, and she does everything, and she gets her yearly mammogram. She says, I'm going to live to 110, and so she still do her mammogram. So I love it. I love her attitude, and it makes me feel happy. So I never say there's an end date, but I do tell you that most guidelines says after 80. So that's just because of the lifespan that we're in this day and age. So one thing about starting at 40, so there are some guidelines that says that you should do it every year, and some says every other year. I am an advocate for doing every year, basically because prevention. We just, things can change pretty drastically. Clinical exam, self-breast exam, they're all you can hit or miss. But if you have a family history, if you have a lumps or dense tissue, really you should do more yearly. If you're afraid of radiation, which is one of the biggest fears that most women come into office is, I don't want to do it every year because of the radiation exposure, then do it every other year. But at least, if you have daughters, aunts, nieces, cousin, whoever young, tell them to get at least a baseline mammogram at 40 for comparison. If whatever interval they choose to, at least do one at 40, and then interval they can choose out just for comparison, because it helps the radiologist, it helps us determine if these lesions had grown, or they were there, or they were new, or anything like that. So that's breast cancer. So please schedule your mammogram if you haven't done so. Okay. Next topic is uterine cancer. Uterine and endometrial cancer. Endometrial just means the lining of the uterus. This is the female anatomy. A lot of patient comes in, they're like, what does my anatomy look like? I mean, this is just a cartoon. This is the uterus, and the endometrial lining is this lining in here that where your lining, your period is growing and shedding. Your cervix is here, your ovary, fallopian tube, and the vagina obviously here. So majority, about 70-80% of uterine cancer actually comes from the endometrial lining. And that's why I put the endometrial uterine cancer. You can have cancer out in the corpus, the muscle lesion, the muscle area. But really, a lot of that comes from this. And endometrial cancer is not as it's common enough, we see it enough, but not most common. Breast cancer is 1 in 8 women. Just spontaneous breast cancer is 1 in 8. The incidence of endometrial cancer is actually increasing. Again, that's due to lifestyle, obesity, weight gain, estrogen exposure. Breast cancer treatment actually is one of the category of tamoxifen and HRT is increasing that risk of endometrial cancer incidence in the US and probably worldwide. So endometrial, the reason for a lot of women that presents with how we diagnose or patient comes in our office is heavy bleeding in between their period if you still have a period. Perimenopausal bleeding, meaning heavy bleeding, erratic bleeding. If you're perimenopausal, if your period's going to start to end soon, generally the trend is you're going to have bleeding for a few months, it gets light, skip a month, skip a few months, eventually it goes away. 12 months of no bleeding is menopause, the determination of menopause. But bleeding, the erratic bleeding, heavy bleeding, anemia to the point where you're bleeding clots and passing clots, perimenopausal bleeding, that's where age of 40, 45 over increased risk for endometrial cancer because the lining is overgrowing and a lot of patients come in for that heavy bleeding. We have to work that up. The other thing is menopausal or postmenopausal bleeding and spotting. A lot of patients don't know that, and once you hit menopause, you're like, I don't need to see a GYN, I don't need to see another doctor. My female parts, you gotta leave it alone. So menopausal bleeding is really important because the incidence of endometrial cancer is the highest is in the 60 years old category of age range, and menopause is when most women are there. I think 3 months ago, she's a nurse. She came in and see me and she had menopausal bleeding, spotting really, and discharge. Didn't think anything of it. It's been going on for 2 years. And she's like, no one told me that was abnormal. It is not normal. No, you should not be bleeding from this lining because technically hormones from the ovaries giving you the lining to bleed from or giving you the hormone to build this lining so for you to bleed. But if you are menopause, you don't have any hormones, so where is this bleeding coming from? It's usually the lining, the pathology inside, either a lesion or something in here, and that is where most menopausal women don't realize that you can have cancer in the lining. Also, the wall, the uterine wall, bleeding can, growth of that can also cause bleeding. So for endometrial or uterine cancer, it's easier to diagnose because bleeding is usually the most common complaints. Discharge as well is abnormal discharge. You get like the mucousy discharge vaginally, but not like brown or yellow or green discharge or pus. That is not good. I've had, several patients comes in with that and it's just not, it always needs a workup. Thickened endometrium, for instance, if a patient had an incidental CT scan, an MRI, have no bleeding, but then there's pain associated with it and she has spotting and it was years ago and it went away or something. Thickened endometrium also needs to be worked up if you have any pain or bleeding associated with it. Usually that's because there's either the fibroid is growing in the wall, a polyp or growth or cancer processes happening inside. So thickened endometrium should be looked at too in a different way than just saying it's just poo-pooing it. So vaginal discharge and then pain. Pain can be so it's so general because it could be from anywhere, but sometimes it's just pain. I have cramps and then all of a sudden I have a spot and it went away and that's it. So the pain can be because the uterus is trying to expel something, so you get the cramp and the bleeding, and that's usually something that we should work up to. Family history of GYN cancer, which is female cancer. There are some endometrial cancer or patients with Lynch syndrome in family category of, or family history of Lynch syndrome. You should be worked up for or get biopsy routine because they're increased risk for endometrial cancer, high incidence. So discussion would be surgery early on or not. Medication, if you have tamoxifen is the chemoprevention for breast cancer. HRT, which is hormone replacement therapy, a lot of our women patients are in 60 or 65 and still on hormone therapy. If you have no bleeding, it's okay, but if you bleed, then you definitely should be off, because then we have to work that lining before you can restart. But hormone therapy is it's a whole different topic. A lot of patient comes and asks for that, and we have to assess your risk. When you one other thing that is very important, if you are on hormone therapy, if you have a uterus and you're on estrogen, you need to be on progesterone. Okay, estrogen and progesterone are two female hormones. A lot of patients are only on estrogen hormone for hormone replacement. If you're on estrogen, you need progesterone, because if that estrogen lining is, what estrogen does is really build this lining. If you have unopposed estrogen, that's where abnormality grow, malignancy and pre-malignant cells are growing. So on hormone therapy, you should really make sure you have both estrogen and progesterone, either continuous or intermittent progesterone, but that needs to be on board. I don't know how many patients I've come in, they have primary care doctor or some other doctor, or all put them on estrogen and just testosterone and whatnot, but no progesterone, and they come with a bleeding, and it's always a discussion that we have to take that out and do further workup. So endometrial cancer, the workup is pelvic exam. I can't emphasize enough the pelvic exam, because sometimes when we do the speculum exam, we see a lesion on the cervix, we see things growing out. We do an exam. Pelvic ultrasound, and this is like, this image just to let you know, is if I'm cutting you in half and I'm looking sideways, this is what a normal uterus is. The normal uterus is the size of about 6 to 8 centimeters. Anything larger could be due to fibroid, you just happen to have a little bigger uterus, any cancer process. But this lining here, I show you this picture because what patient always, especially postmenopausal women, patient comes in, they're always asking why I need an ultrasound, what else I can do besides doing a biopsy. This lining on ultrasound is very important when you're postmenopausal. When you have no hormone, this lining should be as thin as possible. Anything more than 0.5 centimeter or 5 millimeter is an increased risk for cancer if you have bleeding. So when we do an ultrasound, we want to see this lining in a postmenopausal woman to be very thin. Anything thicker, we ask you, if you're bleeding, you have pain, we should just do the biopsy there. That's where we do the biopsy from. So not only pelvic exam, but pelvic ultrasound, sometimes depending on your history, depending on if you're there and you don't want to do the biopsy. But the gold standard of ruling out endometrial cancer is really endometrial biopsy or endometrial sampling. Either doing it in the operating room with a diagnostic hysteroscopy DNC, or doing it in the office endometrial biopsy, which we can do it the same day if you present it with bleeding and problem. We at Washington, I never had that luxury, but now at Washington, the Women's Health Center, we now have the endoscopy that we actually can see and look in the camera in our office to do it just as if we're doing the diagnostic. The diagnostic hysteroscopy is a camera going into your uterus and looking, and then DNC is taking a sample, you under asleep, so it's easier to biopsy and really thoroughly examine the lining inside. But endoscopy in the office is a way of not getting you to the OR operating room, but looking and taking a camera and really looking in and doing a more specific biopsy. If we see a polyp in the office, then we can go, okay, you need to go to the operating room so we can take this polyp out. Or, there's a fibroid, we need to go to the operating room and shave it down, it's causing the bleeding. Or, their lining is too thick, we need to do more. So that's a way, but really the gold standard to rule endometrial cancer is really endometrial sampling, and that's biopsy. It's pretty, I'm not gonna lie, it's cramping, it's very painful, but it's a quick process just to do that sampling. And really, we put a catheter in and we really sample this. It's blind sample, but it's good. It's 99% ruling out cancer in this lining. Okay. The other thing is laparoscopy, which is taking a camera and looking at your belly. Laparoscopy is we're concerned anything outside the uterus, which we need to look inside in the belly. For instance, if we didn't see anything, but you still have a growing mass out here, we don't really know what it is. Either we do surgery or we do just laparoscopy and we look. Or if sometimes, this is a very nice pelvic ultrasound, but sometimes we come back with pictures that we have no idea. There's all these masks everywhere, and we're not really sure if it's uterus or ovary or whatnot. And laparoscopy sometimes help us with that and give us a better picture. CT abdomen or pelvis is something that either you do it incidentally because you came with pain, or I sometimes order them because you have a lot of uterine mass. Usually fibroid is what I order for if we're planning for surgery. But if anything growth or abnormal growth, or I'm concerning more, for instance, that patient who said, I feel bloated, I feel pain, I'm constipated, I end up ordering the MRI because her CT was pending, and that's where I found the mass. Anyway, this is more, not necessarily always needed. An ultrasound is good enough in terms of imaging. So please come see us for your exam if you have bleeding or abnormal bleeding. So we hit this topic, and ovarian cancer it's a hard topic to talk about because the symptoms are so nonspecific. Abdominal pain, pelvic pain, a lot of us have that. Unintentional weight gain, weight loss. Really, it's a conglomerate of all these symptoms. I would say more would be higher suspicion. If you come in with just weight loss, I can't really tell you, that I can't tell you that's the risk, but generally it's like multiple symptoms. The weight gain is really abdominal. You're gaining the girth, the abdominal bloatiness around the belly. The nausea and vomiting and loss of appetite attributed to the weight loss is also one that I see often. Changes in bowel habit, constipation, diarrhea, really constipation. I haven't seen much as diarrhea, but constipation. And this shortness of breath, I just add in because it's really non-specific, but the reason I say this is so many symptoms that it's hard, but so it's kind of like, I can't tell you what is what, which one is which, just because ovarian cancer is so hard to diagnose. We just don't have a good screening. Ultrasound can give us a little bit of some information, but the symptoms are so all over the place. But if you come in with female-related issue or these symptoms, like multiple symptoms like this, please come see us because it's just one of those things we don't know. Shortness of breath, probably because of the stage 4 when it has invaded her lungs. So it's a difficult diagnosis, and usually when we diagnose a patient, it's usually stage 3 or stage 4. Treatment is usually surgery, whether neoadjuvant chemotherapy before surgery or surgery and then chemotherapy. It's one of those, but it's usually just such a difficult thing to diagnose though. So the workup is pelvic ultrasound. Again, if we're suspicious, we've an exam and something doesn't feel right, you have pain. First thing is we do an ultrasound to see what your ovaries look like. They're really small. Usually cysts you can see, but ovary on an ultrasound is really small. It's about 2 to 3 centimeter. Normal size for a young reproductive woman is between 2 to 4 centimeter. Cyst makes it larger, and obviously. The other thing is, I didn't put in pelvic exam, but really important pelvic exam. I always bring stories from my office because this is how I diagnose some of them. As one patient came in for pain, really just pain, and she said, I just felt this right-sided area and really pain, and I did an ultrasound, and the ultrasound says a 10 centimeter cyst on a postmenopausal woman. She's postmenopausal. And I said, a simple cyst. Studies have shown if it's 10 centimeter and simple cyst, you don't need to do surgery because likely it's not malignant. But her symptoms, her presenting symptoms, her other associated symptoms, I kind of got suspicious, and so I went ahead and referred her to an oncologist to do surgery. Borderline cancer, and that's the only symptom she came in with, just this right-sided pain. That's it, discomfort. And constipation, I think, like a mild constipation. So Pelvic ultrasound is very important, but listen to your body too. I mean, we do all these workup, but ovarian cancer is so out there that if you feel something is out, please just come see us. Blood work is really, these blood work are very non-specific. It's just a way of us to rule out or rule in something, but not really say confirmed. So CA-125, I don't know if you hear about, some of you may hear, CA-125, if it's negative, it's good usually, but it doesn't rule out specific 100% that you don't have cancer. It's a blood work. If you have a cyst and we are suspicious, we're taking you to an operating room, or we just want to see if, you know, there's no growth, but we want to see. Sometimes we do the CA-125 just to see the risk of malignancy risk. In menopausal women, the CA-125 should be very low. If she is high, then she's get referred to an oncologist. We've got an oncologist for surgery. OVARIAN is another blood work we do. It's really just to see the risk factor again. It's part of a lab work to say, are you at high risk for ovarian cancer? We go in, we do surgery. Should we have an oncologist stand by, or should we, you know, send you to an oncologist? CEA is another blood work that I point this out because some of my patients ask me, Dr. Tran, why do you order these? If I have a cyst or I'm suspicious, I said, these are the labs I'm ordering, these are the reason. CEA is just to rule out GI stuff related, intestinal or stomach issue, cancer risk. The other thing is any big cyst, any big mass in the pelvis, CT scan, MRI is best. MRI, the difference between CT and MRI really, MRI if I'm looking for muscle, I'm looking for tissue. CT scan is just a quicker way of going in. You get the CT scan a lot quicker. There are some signs and symptoms, some signs and some lesions on CT and MRI that indicates metastasis or things like that. Sometimes pelvic finding, we go in, again, that patient I did an exam, it was turned out uterine cancer, but my suspicion really at that time was ovarian cancer, the one that had the 20 weeks mass uterine cancer. My first thought was ovarian cancer, but that's an incidental finding. And sometimes I examine and I'm thinking this is a fibroid, large uterus. Turns out it's really ovarian, and that's where we go from further workup. And surgery, the surgery in hysterectomy patients, if I go in and I see the ovary doesn't look right, I will send the ovary out and take that out. And I always tell the patient, listen, I may take it out. In terms of your question, if you still have ovary, you still have the risk for ovarian cancer. Sometimes in a hysterectomy, people, you hear about total, subtotal, partial, whatnot. So hysterectomy just simply means I'm removing your uterus, that's it. Total hysterectomy, I'm removing your uterus and your cervix, so you don't have any cervix left. No more pap smear needed in case. But total hysterectomy with bilateral salping oophorectomy, or BSO, means I'm taking both ovary out. So I guess the partial for some patient means they're leaving the ovary in. And subtotal for some, in some category, is still leaving the cervix in. So in terms of like having the ovary in or not, when I counsel a patient for a hysterectomy, whether I leave the ovary, I usually recommend leaving the ovary if she's still young. If she's over 65, I say take it out, decrease the risk of ovarian cancer. But if you leave the ovary, you're still increased risk for ovarian cancer, because you're just technically, I didn't do anything. Your ovaries are still there, the risk is still there. I tell patients, whether I remove the ovary or not, your risk of ovarian cancer is still the same because you still have the ovary. There are sometimes hysterectomy, if you have a very a surgeon sometimes comes in and we don't really open a patient's belly up, and you look and there's like a mess, uterus is stuck everywhere, ovaries are stuck in adhesion depending on her surgery, previous surgery and whatnot, or depending on all the scar tissue that she's formed over the years. Sometimes we can't remove the ovary completely. We say we do, but we can't remove it. And if I can't remove it, I usually tell a patient, listen, I think there's a piece of ovary still left. You can still get cancer from that piece left. It is unfortunate, and I've seen that case happen before. As for your question about the tubal ligation, there are several techniques. Tubes, is just a floppy thing. Either you just burn, clamp, or cut and piece, right? So now we actually recommend removing the entire tube and what we call salpingectomy if you're doing a tubal ligation. I now exclusively just do the removal of the tube because they have found the incidence of ovarian cancer. They believe some of the ovarian cancer is coming from the fimbriated end of the tube. So by removing the tube, you reduce ovarian cancer risk. So if a patient is not planning for kids and, like, we're just in there for surgery, might as well take the tube because the risk of ectopic pregnancies decrease, and also to decrease the risk of ovarian cancer. There's discussion about decreasing blood flow to the ovarian, both ovaries, if you take the tubes out, whatnot. Yes and no, but I'd rather take that risk of ovarian cancer out for me. And the decrease in ovarian function is very minimal, if not even noticeable at all. You're not really touching the ovary, you still have the ovary. The blood flow, the ovaries has several different blood flow. The one main flow from the upper part of the body, but the uterine blood supply to the ovary is minimal if you think about it. There is some talk about birth control pills if you, as a young female taking for birth control. If you take it a year or so, or 10 years or so, you decrease the risk of ovarian cancer. You lower your risk of ovarian cancer. The theory is that because ovulation, every month you're cycling ovulation, by giving birth control or preventing ovulation, therefore no pregnancy, you actually decrease inflammation around the ovary, and cysts. You decrease cystic formation, so you decrease the risk of ovarian cancer. Birth control pills are or hormone therapy treatments. There's just it's back and forth. There's the estrogen risk to the breast, and then there's that benefit to the ovary, so which do you take? Really, if you use birth control, I tell patients just use it for birth control. Don't think about your cancer risk. Either to prevent cysts or for contraception, but it's not really, I wouldn't use it for cancer prevention. And then salpingectomy is the removal of the tube. I talked about removing this entire tube. Again, the idea is this fimbriated end that is where ovulation occurred, and the egg is traveling down, and these fimbriae and are catching the egg. These little finger-like things are changing cells a lot, and that's believed where a lot of the changes in ovarian changes, fallopian tube cancer are coming from because of that end. So by removing the tube completely, I am removing that pathway from the egg and sperm to remove you doing tubal ligation. And the risk of ectopic, instead of just cutting here and the possibility of the tube coming in, and I decrease that ectopic risk. So I tell a patient, I'm just removing it and decrease your risk, unless she tells me otherwise. She's done research and whatnot, doesn't. And the blood supply to the ovary is completely different. There's a blood supply out there, and then the uterine supply is different too. And then removing your ovary, removing your ovary means you're going to go in menopause. Either you let it natural menopause, your ovary is going to shut down, but removing the ovary in menopause, and not a lot of young female would like to hear that. But really, for BRCA positive patients, if you have or known anyone with BRCA positive, this is the Angelina Jolie effect. Her mom had BRCA, she had BRCA, and she had the mastectomy and the oophorectomy and now hormone therapy. The BRCA positive patients, the risk of breast cancer is 40–60%. The risk of ovarian cancer is in the same category. So by age 40, if you're BRCA positive and young female, I tell them, please get pregnant, be done with childbearing, and remove your ovary by 40 because the risk of cancer is so much higher in the population. Most breast cancer are spontaneous. Genetic breast cancer is really about 15% of those cancer. So the population for BRCA is not high, but on occasion I've had several patients come in the office with BRCA positive. Also, who's BRCA positive? A certain population, Ashkenazi Jewish especially, but genetic testing, we have that testing offer in our office. If you have multiple family members, usually same side of the family, under 40, with breast cancer or with breast and ovarian cancer, you should have them get tested for BRCA, or we should, yes. Moving on to the next topic, cancer, cervical cancer. So this is probably the #1 reason why most patient comes and see us for just their routine preventive visits. Cervical cancer, it's a lot less in worldwide because of, or a lot less in the US because of the screening that we do. And also the HPV vaccine that's now given to younger females. So sometimes it comes as just discharge, abnormal bleeding, lesions on the cervix that pop up and then it bleeds, vaginal or pelvic pain. And if you have advanced growth, pain and discharge is usually the two common complaints of cancer. I put infection in there because a lot of patient comes in and they're like, oh, I have this constant, like I'm always having discharge, I'm having infection. And sometimes the workup, then you find out, I do a biopsy on the cervix or I collect some sample and sure enough it comes back with some abnormal cells. So infection is also one of the symptoms that some patient comes in with. And also just no symptoms at all, none whatsoever. Just the cervix, the abnormal cells keep growing, but you have no lesion until it's really advanced, or no symptoms until it's really advanced. So pap smear screening is very important, just to kind of prevent that. So this is where a lot of women come in with a lot of confusion because I've been out of residency for almost 5 years in training. I trained since 2010. And the guidelines have changed so many times, or not so many times, but enough to me to see. Used to be pap smear was every year, and then somehow along the study, some more study came out and says we're doing too much, and then it kind of deterred women to coming to see us because we don't like pap smear. To be honest, I really don't like pap smear either. If you like pap smear, you should really see another doctor. Really, you should not see me because pap smear is not fun, but it's needed. The interval for pap smear now has really been a little bit more standardized, but before it was iffy. Is it 1, is it 2, is it 3 or 5 years? The 1 year is, some older patients still feel the need to do it every year because if I had it every year, do you need it every year? No, it's technically not every year. Usually a year follow-up is if you had some abnormal cells that we need to see you within a year again. Current recommendation is actually 3 years. 5 years if you add in the HPV, high-risk HPV with it. I think right now in our practice we chose 3 years as a running number to come back for pap smear. 5 years is a little too far out for some patients, and if you tell a patient 5 years, I don't know, but I've seen enough where a patient wouldn't show up until 10 years later. I don't need another one for another 5 years, so why do I need to come back sooner? To me, 5 years is a little far out, but this discussion is to talk to your doctor and say, is it 3 or 5 years? I've always been a 2 or 3 year person. 2 years because some patient comes in and they still will pay out of pocket, or they say insurance will cover. Actually, insurance still will cover every year. Some insurance will. But we now just chose to do 3 years because the guidelines are going to change, insurance is going to change soon, and 3 years is usually now the running number in our office. 3 years really is just plain pap smear. I'm just collecting some cells right here. So the cervix is down here, and I'm just collecting these cells here and sending it off. That's just 3 years. 5 years if I run these cells and then I run the high-risk HPV. High-risk HPV are 16, 18, and 45. If you are negative for both, you're good for 5 years. And the reason why the spread out longer interval is because cervical cancer takes a long time to grow. Unlike uterine cancer, unlike breast cancer, it is very slow growing, and it can take up to 8 to 10, even 12 years. Or from normal, abnormal to really cancer, it can take a very long time for a patient to develop cervical cancer. So spacing out, we figure by the time you come back, you'll have more screening in. So that's why the spacing out. So we still have out in the community, some docs still do pap smear on a very young female. It's actually not till 21, even if she's sexually active before then, not until 21. So if you have daughters or granddaughters or nieces and all that, 21. You do not need to do sooner. The reason is because the link to cervical cancer comes from high-risk HPV. Most young female will get rid of the HPV over their lifetime. If you're staying healthy, you pretty much will get rid of it. It's just a virus that eventually you'll get rid of. When do you end pap smear? A lot of patient comes in 65. 65, you have no abnormal pap smear, no prior history of abnormal pap smear. If it's just a mild, like one abnormal long 20-something years ago, you're still in that category 65. Or you have no cervical procedure done on 65. So the American Cancer Society actually extended to 70-year-olds. So if you want to do a couple more, then you can definitely do it till 70, and it's okay to do 70. So I have some patients who still do them at 80. Again, that's just their thought process. They do them every year, they should get them every year, so it's okay. And then when the other part to end is, some patients don't realize this, but if you had a hysterectomy and you have your uterus removed, your cervix removed with a total hysterectomy, you do not need a pap smear. However, you should still get a pelvic exam yearly, or not every other year or a few years, because, again, there's a lot of other parts of the vagina, because the vaginal cancer can occur too. And that's where we would like to examine you here. Pelvic exam, lesions that can grow in there. If you have the reason for going away with pap smear after a hysterectomy, is the theory is you cut the cervix, you're done. But if you have any history of dysplasia or an abnormal pap smear or procedure done on a cervix for dysplasia, the risk of, we sew this cuff up, but the risk of cancer can be on that cuff as well. So if you have any dysplasia, you should really still get your pap smear screening, even just a vaginal pap, even if you had the hysterectomy. Most cervical cancers linked to HPV, about 90, almost 100% maybe, 97 really, but these are the three main ones. There are multiple, there's up to 15 if not more linked to, but these are the high-risk HPV that we actually test for. If you have 16 and 18, that can account for about 70 to 80% of cervical, if your dysplasia linked to cervical cancer. So 16 and 18. So if you do a pap smear and it comes back 18, like abnormal, slightly abnormal, but comes back 18 or 16, we need to proceed with further study even though you had previous normal ones. Any previous history of cervical dysplasia or cervical procedure, some patients, they feel like, oh, I had a procedure done, I'm done, I'm not, I don't have to have, I'm back to normal. Actually, I find that patients with LEEP procedure or any procedure, most of those patients really need shorter interval screening. Comes back years later, normal, and then something abnormal comes up, and it's usually need further. So if you have any history of that, really make sure you do get your routine pap smear. Follow-up, so pap smear screening, we collect some cells, but follow-up, and the reason I want to make sure when you leave here to understand some of the procedures done is colposcopy is a diagnosis, is a further exam under a microscope, but some patients are like, oh, I got screening, I was negative, and then they have slightly abnormal and don't realize that that's just screening. It's just like any screening. For colposcopy, it's just to confirm if we see something more, we do biopsy. And the procedure is also like a pap smear, but it's a little bit more extensive. So the screening, we call you back and say, hey, you need a biopsy. If the biopsy is good and it shows, okay, slightly abnormal cells or low grade or something that can be followed, just a routine pap smear, we're good, but we still need a biopsy, just like you do your mammogram and then you get a biopsy. And then further, if the biopsy here shows that you have an advanced cervical dysplasia, then we need further biopsy to remove the cervix, part of the cervix, and excise it and remove those abnormal cells, either in the office with a LEEP procedure or a cone biopsy in the operating room. It's considered a diagnosis as well as a treatment for some patient because of the advanced cervical dysplasia. So if you have a LEEP and cone biopsy, and you probably understand what I'm saying, but in terms of the biopsy, it's just to remove the abnormal cells, and then we have you do a shorter interval pap smear, either 6 months to a year, to make sure this is reverted back to normal. If it's not, then we do even closer follow-up. In terms of prevention, the HPV vaccine has been out there. We all hear about it. Gardasil for young female after 11 years old. So 3 series injection. It's really to build immunity to protect most patient from the 9. There's not. It used to be Gardasil was 4. It covers 4 HPV strand. Was 16, 18, 6, and 11 for genital warts. But now it's covering 9, including 45 and the other 30 series of 30s. It is still 3 injection. If you don't know, it is one today and then 2 months and 6 months. So it's really a 6 months out. Because studies end at 26, that's the reason why it's approved for 26. But now FDA has approved it to be over 45. I'm sorry, cover 45. However, insurance has not covered that yet, has not on board with that. So we actually have to fight with insurance to get you covered. But I have patients who have cervical dysplasia, end up getting procedure and colposcopy, ask, why can I get the HPV? And I say, yes, just get it. What it does is it protects you from getting the other strands from new ones. Now, there's a lot of the population, the shift and change in population as well. I have divorced moms, I have moms out in the scenes, or women who are now dating and all kinds of other scenarios and are re-exposing themselves to HPV. And as you know, HPV is sexually transmitted. If you are in that category of never had cervical dysplasia or never had HPV, probably consider getting it if you're out in the scene again. And there's no age limit really. It's just approved to 45. If it's not covered by insurance in our office, it's about $900 for all threes. I know it's expensive, but for some patients, very worth it because we really do not want colposcopy. Wear condoms, again, on the cervix because it's transmitted to the cervix. HPV has been linked to also anal cancer, throat cancer, all the cancer, any mucosal that are, because HPV is a virus, it goes on to, attaches to cells that are rapidly changing, and cervical cells, that's where there's a higher incidence of those cancer risks. You can get rid of the HPV once you have it. Your body can build immunity to the virus, so stay healthy. And if you smoke, stop smoking. This doctor thing, my doctor says stop smoking. My short career, I think I'm relatively young. I'm the youngest in my group. We're in a group of 9 women, but one of them says she's never diagnosed cervical cancer. And so far I have diagnosed cervical cancer, uterine cancer, ovarian cancer, fallopian tube, I've diagnosed all. But cervical cancer seems to be the driving factor. Like everyone who comes with, they'll have abnormal pap smear for years, normal, and then I'll do some screening and somehow it comes back. It's a history of smoking. So cervical, if you continue smoking, you're making the dysplasia worse. So stop smoking. So need a pap smear? Please come in and see us. Trust me, I don't like to do them either, and they're not comfortable, but just do it. And then one topic that not a lot of women know, but this is something that's seen more, older population, vaginal and vulval cancers in the 70s or 80s generally. And the reason is because of the estrogen, there's no estrogen barrier when you're older in the vaginal area, just because you're older and cancerous. So it's very rare. A lot of symptoms are very nonspecific, but really itching, irritation, and pain that's persistent. Bleeding from sores or vaginal area, unexplained, not from cervix, not from uterus, nowhere, but it's from vaginal area. Open sores or ulcers. Persistent rash seems to be a very common complaint. They treat it multiple times with multiple topicals, over-the-counter, anti-itching. Multiple doctors treat them for yeast, for some other infection, and then they failed multiple treatments. And so, biopsy. If you tried multiple treatments and you failed, biopsy is usually the way to go. It's the gold standard. So if a patient shows up and she's like, my primary treat me, my dermatologist treat me, and I have this lesion, it's just there, it's all over the place, and it just feels like it's irritating. Patients always don't want to do biopsy because it hurts, but only way to rule that out is biopsy. So very important. So I usually give them okay, I'll give you a trial of this, and then if you don't, come back. And please do come back for the biopsy. Usually it's more like pre-stuff, either hyperplasia, you get other condition, but at least we rule that out. So it's rare. And then I want to touch base on colon cancer because not a lot of female, you come into my office and we're like, oh man, I got hounded, now you're gonna hound me again. No, it's really important. I think it's really important because it's so preventable, and it's just one of those things, just do it and just be done with. Just like your pap smear, you don't like it, but just do it. It really starts at 50 and earlier if you have symptoms, usually bleeding or some other GI symptoms, pain, all kinds of other symptoms I don't deal with, but usually your gastroenterologist or your primary care doctor can tell you. High-risk patients are usually ulcerative colitis, Crohn's, IBS patient really needs to do colonoscopy. And usually by the time they see me, most patients who have been diagnosed already have a colonoscopy. So it's very important to get that. Family history of colon cancer, and this is where I emphasize family history. I go in, a patient show up new to my office, I just drill them with their family history. I want them to give me all their family history, especially cancer. And a few times I've actually referred a lot to the gastroenterologist, but I've seen multiple family members with colon cancer, and the patient's 55 and never had a colonoscopy. Really important, just if you have family history, just get it. Polyp, the history of polyps, and you have colonoscopy, but you have polyps, is closer follow-up. Some syndrome in the family, like Lynn syndrome or HNPCC, polyposis, they really should have more colonoscopy more frequently, and usually by most patients already have a your GI doctor. And this is more of not very well known, or some patient will have to, I have to tell them, diabetic. If you're diabetic, you should get it sooner than 50. An African American population should get it earlier, but really diabetic, you should get it earlier. When do you stop? This age range, whenever you decide is enough. So in a lifetime, you probably get 3, 2 or 3 is enough. Some guidelines says 75, some says 85. Whenever you decide to stop, I had a patient go, I'm never doing it again. At least she got 1. Convinced her to do 1, it was enough, but it's at least no 1. What I do, my part, is either primary care refers you or I refer you to an endocrinologist, and you see them for screening, and then they decide when to take you and when you go ready. It's a 1-day procedure, and then in terms of what they normally do, the gold standard is colonoscopy every 10 years. A patient always asks me, these other testing are they better, or should I do them? The fecal immunochemistry is now every year. It's as equivalent to colonoscopy, but it's a fecal test, stool test. Really, colonoscopy, all these are just to say, hey, you have something, or hey, you don't have something. But if you have something, colonoscopy is the way to go. So I tell patients, if you really want everything in one shot, just get the colonoscopy. If you had a polyp, they remove it there, If you find a polyp somewhere around, sigmoidoscopy, then you would end up having, or CT colonoscopy, you still need to go and get the colonoscopy. So if you want to avoid too many procedures, and you're I don't want to do all this, just go get the colonoscopy. Okay, and then it's shorter interval for these are the time frame for the screening, but shorter if they found polyps or adenomas. Your GI doctor just will follow up with that, or your primary care doctor will. I on occasion do rectal exam on patients who complain of rectal bleeding. If any concern for any rectal lesion or bleeding or something, sometimes I do them for my 65 or 70-year-old patients. Not all, but just to let you know, some of us do them still. And the take-home message really today is, I hope you learned something. All these screening, either helped you reiterate some of the stuff you already know, but really to just kind of understand some of the testing, why you would come to see us, the testing that we do, and just why it's important to do those things. But really take care of yourself and listen to your body, and if any symptoms or any female concerns, please come see us. Really be proactive and seek help, where a lot of women are, years and years of taking care of family members, stress, and kids, and husband, or family, or whatnot, and we kind of let go of ourselves, and we forget that, but take care of yourself. Really, I sometimes have to remind myself every day. I have 2 daughters, and they take all my energy away, but at the end of the day, I still have to if I can't have mommy time, I can't take care of them, that kind of thought process. So be proactive. Know your family history, know your symptoms, family history, routine exam. Please see your doctor regularly. One thing I do emphasize is your primary, your OB/GYN, whoever do your pap smear, doesn't matter, but see somebody so you get routine exam, your labs, your cholesterol, your diabetes, all that's important too. But sometimes on occasion we'll pick up stuff that you never think about. So that's, to me, it's just, I'm a doctor, so of course I tell you that, but just see your doctor. So make an appointment and see us. So thank you for coming.